Hello and welcome to this Rural Doctors Webcast. Now, this is the first of two programs that look at a remote car accident resulting in trauma. We follow a country GP as he comes across a car accident and manages a multi-trauma patient. This program focuses on the scene of the accident, while the second looks at management of the trauma patient once they arrive at ED. Now, at each point, Dr. Olga Ward discusses the GP's progress with emergency physician Dr. Gary Wilkes and Deputy Medical Director at RFDS, Dr. Sally Edmonds.
Well, Sally and Gary, welcome to the program.
Thanks, Olga.
Thanks, Olga.
Well, today we're going to talk about trauma scenarios and most specifically about a rural car accident, which is something that strikes dread into the hearts of all country doctors. I think it probably causes quite a significant amount of stress because you know, you're always the one on the scene or in the hospital. You're always dealing with it. First up, first on. Got any advice in general for approaching trauma, Gary?
Or trauma in a scenario like that?
Yeah.
First thing is to be aware it creates dread. And why does it create dread? We know it can happen. We know it might happen. If it does, it takes a kind of time urgent and fairly expert response to it. And we don't get to see it all that often. So the only approach to it is to be prepared for the unexpected. Go to courses, go through your learning, practice it as much as you can. Prepare yourself, prepare your department, prepare the people around you.
It's always great to have a good team. Sally?
And if you can possibly get the team together from time to time and really work through what you might do in a case, I think that's very important. Yeah, knowing your skills, maintaining your skills and knowing where your local help is very important as well, I think.
And I think certainly from working in very small rural places, knowing what is and isn't available in your emergency department.
Yeah, also.
Which has always been good. Well, let's have a look at the dreaded scenario. Country doctor coming across a car accident on a country road.
Ambulance.
Hello, ambulance. What's the nature of your emergency?
I've got seems to be a two-car collision.
What's your location?
I'm about 14 kilometres up Werrajong Road, north of Ballina.
Do you have a crossroad or road marker?
I just went past Clifton Road.
I have your mobile number as 0473 919 359. Is that the right number to call?
That's correct, yep. Are you okay?
Oh, hi. He was just in the middle of the road. We just came around the corner.
Don't worry about that right now. Are you hurt anywhere?
No, I think we're all right.
Okay, just a minute. Are you okay there? Okay. She seems to be okay. Was there anyone else in this car with you?
No, just
Okay,
us.
thank you. I'm just going to have a look at this guy. You guys just wait here in the car, all right? Yeah, I've got a woman and a girl in a car. I've got a guy lying on the road who seems to be unconscious. He's having breathing difficulties.
So 3 people involved. Anyone else?
No, not that I can see.
Are you with the patient?
I'm just going to check the guy now. Just a minute. Mate, can you hear me? Hello, mate, can you hear me? No, he's not responding.
Are there any chemicals or other hazards involved?
There's something leaking out from underneath the car. There's a bit of glass around, but apart from that, no.
Is anyone trapped?
I don't think so. Just a minute. Hello? No, no one's trapped.
And do you think he was thrown from the vehicle?
I think he's gone through the windscreen. The windscreen's broken and he's lying on the road.
And he's not completely awake?
No.
Is anyone else unconscious?
No, just him.
Are there any obvious injuries?
He's got a gash to his forehead, which is bleeding quite a bit, and he's what I suspect is an open femur with a lot of blood.
So he's bleeding?
Yes, he definitely is.
I'm organising the ambulance to help you now. Stay on the line. I want to talk you through a few things.
Yep.
You said you're a GP?
I am, yep.
Okay, keep your phone handy.
Yep.
I'll see if we can get one of our clinicians to give you a call back.
Okay.
I'll get some more information and help you while the ambulance is en route.
Yep.
you now to do what you can.
Okay.
Remember, keep yourself safe,
Yep.
especially from traffic hazards.
Yep.
Put your hazard lights on.
I did, yeah.
If the patient gets worse, call back immediately.
I will do. Thank you very much. Mate, can you hear me? Hello, mate, can you hear me?
Okay, well, guys, that looked horribly familiar. What do you think?
I'm not sure the doctor would be saying no, no, no. I think some other words might be coming out as they come across the scene. That's pretty frightening, pretty confronting to come across a crash like that. Anyone who's been in a crash will recognise that that's exactly what it's like. Those who've never been to one would see a few things a little bit unfamiliar there. As clinicians, we want to start talking about the injuries and what's going on, and yet that's not the information that the doctor was relaying to ambulance.
So one of the things that struck me was, he made a call to ambulance. That's a road crash. Does that not also need to be reported to police, or do the ambulance automatically ring up the police for you?
The ambulance will automatically ring up. All the 000 services communicate where need be. When there's more than one person at scene, generally they all get called by various people dialing in 000. It's quite common to have multiple calls. In this case, there's only one. But so the doctor is calling ambulance. That's what the doctor is most familiar with. Ambulance will realise it's a motor vehicle crash and contact the other authorities.
And the thing I liked was the doctor actually knew what road he was on and where he'd been, which I think sometimes, you're driving along a country road and you suddenly think, cripes, I'm outside John Smith's farm. Where's that?
Yeah, the other thing I liked was that the doctor actually had his phone with him and was in an area of good reception, because you can't always guarantee that.
Always guarantee it.
But knowing where he was and getting that communication going straight away is really important.
And the other thing I noticed was that this doctor actually did kind of a survey of the whole scene. So, there were 2 vehicles, there were 3 victims.
Yeah, it would have been very easy, wouldn't it, to have gone straight to the fella lying on the road and not to have looked at the rest of it. And I think when you observe a scene like this, it's something to really take note of, the need to see who else is there.
It's really good to see him checking to make sure there wasn't anyone else in the vehicle, because people can get thrown out the vehicle, or in this case they are thrown out but on the road, so they're obvious. They can easily be thrown out or be dazed and wander off. So to take that big step back and have a look around and make sure everybody's accounted for is just so important, because once you go to the sickest patient and start treating them, you tend to lose perspective of what else is going on around you.
I noticed as well that the doctor got on and got the communication going early, and then was talked through a few useful things as well. So he was already looking to see who else was there, but then they prompted him to have a look in the damaged vehicle to see if there was anybody else trapped. And that helped.
And I think occasionally, what you'll miss is maybe the baby in the capsule because the roof's squashed in, or you'll miss something that, later could be horribly regretted. So, terrific.
But it's quite reassuring that he was talked
that
through
it was
it as
talked
well.
through. Yes, Gary, is that common that the ambulance will actually talk you through your scene a little bit?
Oh, absolutely,
Somebody
because
on the
most of us will just want to go straight to treating people, and we're not familiar with being in environments like that, and we don't spot the hazards. We're on a road. You have to put your traffic lights on. You have to think about traffic control. When police arrive, they'll help look after that. But in those first few minutes, you're just as much in danger of being hit by another car coming along the road as anything else. So you must take those things into consideration and deal with them.
Yeah. So now, if you were trying to park up at an accident like that, which looked like it had happened on a bend, where would you park?
Well, you want to park in a position where you would be the first thing that would be seen, with sufficient warning for people that there's something wrong and time to slow down. So you'd want a straight stretch before getting to you. Ideally, you not on the side of traffic where someone is coming through, with your hazard lights on so they can see something is wrong as they approach. That way they'll slow down and see you with warning before they then drive over the people who are involved in the crash itself.
So just doing that kind of step back and thinking, gosh, you know, maybe I should move my car a bit further back and put the flashes on so that people can see.
If you can, or if you have someone else there, then you send them
Toss in the car keys
upstream
and
and downstream from the traffic on the two sides to get a point where they can wave people down and tell them to slow down and stop.
How common is it for the treating doctor, but you know, the person who's got out to help, to actually be injured?
On a rural road, less common because there's less traffic. But when they are injured, they're injured worse because the speeds are higher. To give you an example, I suppose about every year or so in metropolitan Perth on the freeway, people are injured or killed after having stopped at a non-major incident where they pulled their car off to the side of the road, and then they do something to change a tyre or do whatever, lose awareness that there's traffic around them and step out into traffic and get hit. It's very, very easy to do.
When you're looking at this kind of accident, what sort of, Gary, you're an emergency physician, what sort of things would you be taking in to kind of get in your mind what sorts of injuries you might be seeing?
Well, you can get some obvious injuries from the patients that are there displaying them, but there's lots of clues as to the forces that have occurred by the scene around, whether the cars have stopped and are against each other and not damaged, or whether they're rolled, thrown over, gone up against a tree. In this case, someone's gone what looks like through a windscreen and thrown some distance, so that's quite a bit of force involved, which means the potential to do injury is really quite high. The other car, not too badly damaged, lower impact, and people are still sitting inside it, so they're probably at less of risk. So the mechanism is pointing towards the first car, and virtually anything can be broken in that sort of an impact.
So, Sally, what kinds of things are going through your mind when you look at that scene?
Well, there were two cars. You can't necessarily tell straight away what it is that's happened, but the fact that you've got somebody who is out of the vehicle puts them at a very high risk of having serious injuries. And it's certainly something that we see quite commonly in rural Western Australia, whether it's from not wearing a seatbelt and being thrown through the windscreen, or being maybe a backseat passenger or in a ute. So you won't know necessarily, or you don't know whether maybe that person has been hit by a car. I mean, there we've got a damaged car with nobody else in it. But the thrown from the vehicle and unconscious is ringing big alarm bells.
Very big alarm bells.
But he's still alive.
Yeah. This patient, to me, is obviously going to end up in a tertiary hospital. Are there any very essential pieces of communication that you would see about this scene that the doctor needs to kind of document and repeat so that it kind of the message gets through to the end user at the tertiary hospital?
Yeah, well, Olga, I guess you've got the initial bit. He's got to get the ambulance there and he's got to get some help on site. And I think the fact of saying there's somebody on the road injured and a badly crashed car, that's enough to get a priority 1 ambulance as soon as they can. Later on down the track, it's harder to communicate just how bad the damage was and where the risk is to that patient, maybe once he's stabilised and possibly looking a bit better than he does. So some of the useful things would be to know that that was a car accident on the, you know, on what sort of road was it? You know, was it a country road? Was it a high-speed single car accident? Was it car versus tree? How much damage was there to the vehicle and where was the impact? Sometimes someone may have taken a photo of the vehicle and that might be useful later just to help to communicate that. And I've certainly seen where sometimes someone's just drawn a quick diagram to show where the impact was, because whether it was side impact or front on might be useful later.
Those words through the windscreen have to
go for
ring all
something.
the alarm bells, don't
Have
they?
you got anything to add to that?
Yeah, to look at the exact mechanism is really helpful. It's nice to get descriptions. Pictures are actually really, really helpful. They did a study in Auckland a couple of years, well, some years back now, where they took a Polaroid, so that tells you how long ago it was, of the actual scene. And then they took that with the patient into the trauma centre. And as a result of doing that, when they had the image of the scene for the treating physicians, the number of injuries that were missed on the first day went down by 14%. Just by doing that. So you see the image, you get an idea of what potentially could be wrong, and then you start looking for it, which kind of focuses your attention a bit more.
We've all been talking about 000, but I seem to remember on my last CPR course that they were also saying that 112 from a mobile will also ring 000.
Yeah, so try 000 first. If you have mobile phone reception for your network carrier, 000 works on a landline or on a mobile phone. 112 is the universal number for mobiles, because what it will do is it will dial on any available network. So if you're with one particular carrier and you don't
So if you're on Vodafone and you just happen to be out in the country, you can ring 112 on a Telstra network and it'll get it.
If there is a Telstra coverage at that point, it'll go straight through. 112 will also unlock a phone if you have someone else's phone there.
Just for the emergency call.
Just for the 112 call.
Good to know.
Also, Gary, do you know, does any information go back to the position of where the call's coming from within country WA?
Some does. So within all the emergency services, no such thing as silent numbers. They can read the number. The GPS tracking is reasonably good for mobile phone reception, but mostly all you know is the base station from which it's being received. There is information tied to the telephones, but it will be the address of where the account is registered. So if you just happen to be on holidays up in the Kimberley and you're dialing, what will come up
your actual
against
address
your
is
number
Busselton, it'll come up as
will be your
registered
home
to
address.
Busselton.
So that's why ambulance will always ask you, is this the right number to call you back on, and what is your location, as exactly as you can. The road you're on, a mileage marker, a property that you can see, the last road you remember you went past, or even how long you're down a particular road. All those things are very helpful.
Good. So let's go back and see how this scene developed and what happened with the doctor and the patients.
Mate, my name's David. I'm just worried about your breathing. I'm going to try and help you, okay? Okay, that's definitely better. I'm just going to get a device that's going to help you breathe, okay? Bear with me. I'm just going to put this in. This might be a bit uncomfortable, okay? But I'm going to put this in and it's going to help you breathe. Okay, mate, that's better already, but I'm just going to check your breathing and check your chest, okay? Crunchy. Okay, you banged yourself up a bit. Just going to have a listen. It's not too bad. Yeah, tacky and a bit thready, mate. I'm going to have to try and control your bleeding a bit. And I'm really sorry, but the first thing I'm going to do is try and straighten out this leg, okay? This is going to hurt.
Is he?
He will be, yeah. Listen, I'm a doctor and I've called an ambulance and they're on the way. The safest thing for you to do is just stay out of the way, out of the traffic in the car with your girl, if that's all right.
Okay.
Are you okay?
Yep, thank you.
Mate, I'm just going to splint that leg to your other leg and that might help, and then I'm going to put something on that forehead to stop it bleeding as well. Mate, that would be great. Look, there's obviously been an accident. What I want you to do is just go around the corner here until you've got a nice clear line of sight. Put your hazard lights on now if you can. Then just park on this side of the road with your hazard lights on, and then just come back up here and give me a hand. Would that be all right? Yeah. I'll just guide you past this guy. Watch this guy on the way past. Thanks, mate. I'm going to get a splint on this leg for you, and there's a guy who's going to park his car and come back and help me, okay? Hello?
Hello, is that David?
It is, yep.
David, it's Tony here. I'm one of the emergency doctors for the ambulance. Just bringing you back to see how you're going there. Now, I understand you're a GP, is that right?
I am, yep.
Okay, what have you got?
I've got a guy who's come out of his vehicle. I think he's gone through the windscreen. He's got a gash on his head, which is starting to settle down, but there's a bit of blood. I've got a Goodell in. He was having airway problems, which he's tolerating for the moment. He's got some bruising and had some diminished breath sounds on the right-hand side and some broken ribs on the right-hand side, and he has an open femur.
Okay, now you said you've got a Goodell in. He's got some kit there, have you?
A little bit, basically just a first aid kit.
All right, what do you have available to splint?
I was just going to use some triangular bandages and splint to the other leg at the moment.
Okay, have you done that yet?
I haven't, no.
All right, is he the only one who's injured?
He's the only one who's significantly injured, yeah. There's a mother and daughter on scene, I'm assuming, but they seem to be okay.
All right, is someone looking after them?
Not at the moment, but I've got a guy who's just arrived who can come back and can help.
All right, you make sure someone looks after them. Now, he was lying on the road when we got caught before. Is he still there?
He's lying right in the middle of the road, yep.
Okay, the information I've got is the ambulance is still about 15 minutes away.
Yep, 15 minutes.
Can you just make sure there's no contact of skin with the road? He's going to burn in the heat out there today.
Okay.
See if you can get some shade on him. I wouldn't move him at this stage.
No.
At least in time.
No.
I think you've done all you can with what you've got available there.
Yep, I will do, thank you. G'day mate, my name's David.
How's it going?
I'm
Jared.
a GP. So, can I get you to just go over to this car? There's a lady and a girl in there. Just make sure they're okay.
Yep.
And also just see if you can find something that we can put underneath him to protect him from the road.
No worries.
Thanks.
Hi guys, how you going in here? Not too bad. Do you mind if I just grab that jumper?
Oh, sure.
You want a jumper?
Cool. Okay, cool. This one, do you want to just pop that underneath his arm over there?
Yeah, no worries.
Great, and then I'll get you to put on some gloves. There's a bit of blood around. That's it. Just pop those on. We'll put that under in a minute. What we're going to do, mate, is just splint his leg to his other leg.
Yep.
So I've got just some bandages here. I'm going to carefully feed them underneath. And I want you to be around this side and very, very gently. Just take it when it comes underneath and just put it down for the moment, and we'll tie it up in a minute once I've got a couple of them underneath there.
Okay.
So let me just get rid of this for a second. I'll just move this leg up a bit. Just very, very carefully. Just take that in underneath there. Okay, pull it through a bit till it's about middle. Okay, and then just gently slide it up. Try and slide it up. That's it. That's it. Okay, just leave it there for a minute. We'll do one more. We'll put a third one on the ankles in a minute, but for now, let's just get these ones under. Just take that through there. You got it?
Yeah.
Nice and gently, nice and gently. That's it. Okay, cool. Just leave that there for a minute. I'm just going to pop this in there to pat it a bit, protect one leg from the other leg. Okay, now we're going to tie it off, okay? I'm going to hop around here. I'm going to hold these legs together, okay? Nice and tightly. I want you to just grab this one. That's it. Just have it ready. I'll just pull these legs in together. Okay, nice and tight. That's it. That's it. And again, double knot. Okay, great. Let's do this one as well.
Yep.
You got it? Okay, I'll just hold his ankles.
Is that all right?
Just a bit further down. Just try and keep away from that. Yep, great. Just tie that off.
Okay, well, it sounds like an awful lot happens all at once in the accident scene, but really what we're looking at here is primary survey, isn't it? Airway, breathing, circulation. Gary, any points that kind of struck you about that scenario?
It is frightening, and it's confronting for someone to be at a scene like that. But I like the fact that the doctor's talking out loud what he's doing along the way. He's actually talking about airway. He's told the patient he's looking at airway and breathing and then going through, which, although the patient's not going to remember it or be able to respond back, it's a great way to keep yourself on track. And he looked at the airway, recognised something was wrong, fixed it, and then moved on. Breathing not too bad, and then went on to circulation. So he was going through a nice process, talking out loud as he was doing it, identifying things and then fixing them, which is just what you want to do when you're in a stressful situation like that.
Yeah, kind of nice to talk through a checklist. What were you noticing, Sally?
Well, we saw him doing some airway manoeuvres and keeping the cervical spine as it was, not fiddling around moving his neck too much or at all. And he's got some good equipment there, which was quite reassuring. I guess we might not always have that, so you've got to work with what you can. But whichever way you do it, it's airway and cervical spine, and then the breathing. And to look at the breathing, he had his stethoscope with him, that was great, but also he exposed and he felt, and I think he watched the breathing pattern, and I think there was some mention of broken ribs. He was pretty sure that was there. And there was already an unusual breathing pattern that we could see on the film, couldn't we? Looked like a paradoxical breathing, and certainly a bit of respiratory distress with it.
And then circulation, I guess reducing the fracture might help the circulation quite a bit.
Yeah, he felt for a pulse and said it felt quite thready. And started looking for where the blood loss was, because there's not a lot of blood lying around at this accident site, but there was potentially quite a lot in the
compound
leg.
femoral fracture that looks like it's probably there.
A couple of bleeding sources, so a bleeding scalp that was dripping blood down there, and sometimes the blood looks like a lot more than it is, sometimes not.
There's a heap.
Yeah, and a clearly...
I've seen a litre out of a scalp wound.
If it keeps going, yes. And in fact, the worry is more when it stops bleeding, as to what is happening to your circulation at that point. But the reducing the fractured femur was good. And that order, what do you do first? Do you reduce fractures? Do you put in a drip? Do you think about fluid? Well, he's only got a first aid kit. So everyone watching this, if you work in a rural environment, think, well, what's in your car right now, and what is going to make a difference? And stopping bleeding is more important than putting in a drip and giving fluid. Yeah,
so just having a great big combine or something helpful and something to hold it on with.
Oh, triangular bandages. Have
Wonderful.
Have 4 or 5 triangular bandages in your car and you can almost do anything.
Gary, can we just talk about this ambulance callback, which I thought was terrific. Somebody trained from there. Who is going to call you back if you're a doctor at the scene of an accident? Is there always an emergency physician around from ambulance?
Yes, there is. They have a range of clinicians they use. There are emergency physicians they can use for callback, and then also within ambulance, there are critical care paramedics who are not only familiar with the scene and the paramedic stuff, but have additional training. Many of them have worked on the helicopter and so done this in real life as well. So one of those will be the person giving the advice. So they understand the medical treatment, they understand the rural environment, and they understand the particular vagaries of being at scenes rather than our more comfortable situation of being in hospitals. Because a lot of the advice that was coming out wasn't necessarily direct medical care, it was some of the other stuff going around saying put stuff on, make sure the skin's not in contact with the road because he's going to burn, and you can burn really quickly on roads. If you ever want to have a bit of fun, get one of your engineers who tests the air conditioning with their little guns that measure temperature, go outside, point it on the ground, point it on the road, and you'll be horrified the temperatures you can reach even on a mild day.
Yeah. So now, that's even with just a 15-minute until the ambulance is coming.
Yeah, now I noticed that they said, is there skin against the road? They didn't do anything about putting something underneath his head. Would you?
Well, it depends. He's got a fair mop of hair on the back there.
A fair mop of hair and a potential cervical spine thing. So I'm just wondering, do you worry more about the burn or the neck?
biggest threat to life first at the moment. As Sally was saying, the neck is already in a good position there. The doctor's not wrenching around and moving it, so don't mess with something that's not obviously an issue right now. The neck isn't moving, he's not moving.
And he's maintaining his airway as well, isn't he? Once the Goodell airway was in.
So if you had a collar, you would put it on. But given that that's not an immediate threat, it's airway and cervical spine precautions, I wouldn't put that above reducing a fracture and doing something about circulation, because the neck is already not moving. We're not going to get any additional benefit right at this moment from a collar. We want to do it, but prioritisation.
Yeah. Are there any other priority things that you think we should be kind of clocking through when we're looking at this kind of scenario?
Keeping the situational awareness there is really important. So he's still out there, our
in the
heroic
middle of the
doctor,
road.
in the middle of the road, and he's still at some risk. The cars are going to be coming in two directions, and it's just so important to keep aware of that.
Knowing that it's 15 minutes is not too bad. You're out on the road, you're in the sun. The hazards are multiple. Traffic is an obvious one. So as people start to arrive, you'd get them to be your traffic wardens on the outside. If anyone's got any medical training at all, which normally people do have some degree, they can help you as the doctor at the scene. And then think about shade. Think about whether, if it is going to be a while, do you need to move off the road? Do you need to let the person stay on their back? This person's got an airway problem. You might need to put them in a recovery position if it's going to be a long time. And that's when you need to think about cervical spine protection. So there's lots of competing priorities here, which will be varied by the injuries that that are obvious at this particular time, and the time frame of how long it is until that help's going to arrive.
Yeah.
And the number of helpers there as well, I suppose, because you'd want one or two with the critically ill patient, but you've got your other couple of potentially injured people in the other car as well.
Who could also, well, not the little kid, but the lady, at least, if not injured, could potentially become a helper if it became critical to do something.
Yeah, what do you think about that, Gary?
Well, she's
in quite a smashed up car, but she's able to walk.
The more help, the better. Why not use everyone? Gives people things to do. She spontaneously got out the car, walked and talked, so we know that she's not immediately dying at the moment. She has a child to look after. That's a priority. You don't want the child wandering around the road. Kids in situations like this tend to go quiet and just cling to parents, but if they are able to get out and are to help, the people who are first at scene are the people involved in it. So yes, they will tend to help each other, would be the reality. If I was there, I'd use them.
Yeah. Now, as the doctor on the scene, I was impressed that the ambulance rang back with somebody who really knew what they were doing and how to handle this type of scene. If, as the doctor on the scene, you weren't quite sure whether or not, say, to move somebody off the road or not, and you had enough helpers, can you just ring back via 000 to get somebody?
Absolutely.
For help, or would you just simply ring you at the RFTS?
The first communication through to ambulance, they would have recorded the number the person was calling from and their name, which they did, I think, in the early part of that communication. And if you need more help, call back. That was the instructions. If you need more help, call back.
Call back, and you just ring back on 000 and it'll come through.
Yeah, one of the really important things, I think, is knowing how long. You know, that must be very helpful to know how long it is till the ambulance is expected to come, because that'll influence whether you want to move him, whether you want to put something under his head, whether you need to shade him.
Yeah, 15 minutes or an hour is quite a different scenario, isn't it?
And the reality is most response times, even in the country, are relatively quick. And that's because most incidents tend to occur where populations are, because that's where the people are. And every population density has an ambulance of some description that is able to respond. So for priority ones, a 15 minutes response time in the rural sector is actually pretty typical. We know there are long times though in incidents where you're out, but quite often you tend to not have mobile phone reception in those areas as well. And as Sally was mentioning earlier, knowing how to get help and having an appropriate phone is quite good.
Let's have another look at the scenario and see how the doctor's travelling.
You're doing a great job there, Jared. Here comes the cavalry, mate. Hey guys.
Hi, how are you?
Yeah, good. We've got a woman and her daughter in the car there. They seem to be okay. There's this guy who's come through the windscreen, I think. Found him lying on the ground right here. He's got a head injury, had some bruising on the right hand side and some diminished breath sounds on the right. And he's got an open finger as far as I can tell. He's got a Gadell in which is tolerating. I'm worried about head injury and I'm worried about his breathing.
Some oxygen on it?
Let's get some oxygen on and then
Anything
put a
else you'd
collar
like?
on. At this point, no, let's get oxygen on, a collar on, and then just get him into the hospital as soon as we can.
Okay. Do you want to take the head for us? Sure.
Jared, I'm just going to take the head, but I'm going to take it from this side, so just hold it until I've got it here, okay? Awesome. I got it, mate.
Can you get a collar for him and
That'd be great.
scoop or board?
Scoop, please.
Scoop. Fine, I'll do that.
Just move it back.
Sorry, can we get help just to remove one and maybe we can just push the scoop slightly underneath him for us?
Yep. Just wait though, we're going to roll him over a bit.
Right.
Do you want me to call it?
Yeah, on your count.
Okay, on 3. You ready?
Yep.
1, 2, 3. And down on 1, 2, 3.
I'm going to go on that.
And again the other
Swap
side.
side first.
Again on my count. 1, 2, 3. And down. 1. Just back a bit. 1, 2, 3.
I'm in at the top.
Yeah, feet are locked in.
Okay, do you want to put the straps on?
Yep.
Just going to pop the head box in.
Just lift gently or?
Just gently, we just slide it underneath. That's good.
Almost there.
And done. What's his name again?
Blake Turner,
Blake.
we think.
Blake. Not been responding to you at all?
Not at all.
Have you got all the straps on?
Yep, right.
I'm just going to pop the head locks up. So if you just move your hand out as I get this block in. Right. On the other side. You happy with his airway and that?
Well, I feel like he's starting to have a bit of trouble breathing. I wouldn't mind getting him onto the trolley and then just do a bit of a reassess.
No problem. We'll get him onto the trolley now.
Yep.
Can we get someone at the bottom? Doctor, do you want to come take this side for us?
That's the head end just up there.
Yep.
Head end.
No worries.
Okay, yep.
So we all grab
So
it.
we'll just take him straight across that way?
Yeah. On the count of 3. 1, 2, 3, left. Watch your feet.
Guys, I'm worried about this breathing. I just want to reassess.
No problem.
I'm going to just check the airway. I'm not going to be able to get in. Do you mind if I take this off for a second?
Yeah, definitely.
No, I've got no air to. That one's fine. No breath sounds. Yeah, his trachea's off to the left. I call that a tension pneumothorax. Do you have a long 14 gauge cannula?
Yeah.
Let's decompress.
Got some betadine here.
Thank you.
Shots. As you need them.
Thank you. That's good. Okay, I can aspirate air. Sharps, thank you. That's great. I'll just check again.
Do you want me to get a 3-way tap?
Oh, that's much better. Yeah, I've got that sounds. Yeah, breath sounds both sides. Let's get that extension tube on, 3-way tap, and then we'll get into hospital as fast as we can.
It looks like quite a lot of things happened in that next scenario. And one of the things that struck me is that the doctor is kind of having another look and having another look. Could you maybe talk us through some of that, Gary?
Isn't it good to see reassessment all the way through? When the ambulance arrive, they kind of take over the scene, which is just great. It's the hospital equivalent of us going, yay, Sally and RFDS have arrived. They know their scene, they come in, they instantly divide it up into the two bits, and the doctor was talking about what he'd found with the patient and still going through that ABC, going through the whole process again, and then let the ambulance get on with packaging the patient up for transfer. That was good because that's their area of expertise, it's their kit, and only they know how to use it safely. What I really liked was the fact that the doctor kept an eye on the patient and reassessing and had to say, hang on, I think something's wrong with here, I need to have another look. And that was a crucial thing to do in ongoing assessment.
Yeah. So you just kind of keep that awareness, something can still go wrong just because you've got lots of people on the scene.
Yeah, and the other thing is that the doctor there's been involved right from the start, and there's so much really still for just the 3 people who are the main players there to do, to get this patient loaded up, keep a quick eye on the other 2 people that are there, that it's great that he doesn't just hand over and head off. which it would probably be quite tempting to do for some people.
Oh, you'd want to have a nice relax and go, I've had enough, I'm exhausted now.
Yeah.
But that...
Although if you're the country doctor, you know that it's going to be you at the hospital when you get there anyway.
Absolutely. That is when things go wrong, though. Whenever during transit and transfer is during transfers when things get disconnected, bumped, knocked out, knocked in, and changed. And during transfer is when you have least access to the patient, and that demonstrated it really nicely. Complication occurred after being rolled, picked up, put on the stretcher, put in place, and the access to the patient was restricted because of all the strapping and stuff that were on top of there. Really real world problems there.
Yeah, and I guess, Sally, that's what you see all the time, isn't it? Patient bundled onto restricted area.
You do. I mean, I guess physically whatever's there that's about to obstruct or whatever's there that's about to bleed will do it when you're moving the person, because everything lines up differently. And then you've got the risk of pulling out tubes and things, which comes on later. But yeah, they did a good job transferring, because the thing is, he still needs to be got onto that ambulance trolley and got to an emergency department. You know, they've not lost sight of that. They did have to stop for a life-saving procedure though, and gosh, didn't they do it well?
No, not many people will ever get to decompress a tension pneumothorax, but it does happen, and when it does happen, it's really, really dramatic. It was nice to see a big needle. Using an ordinary needle that you use for putting in IV cannulas, even a long 14 will only get through the chest 50% of the time in the modern adult male. So having I know it looks huge,
yeah,
doesn't it?
because I was looking at this guy thinking, you know, looks like Vlad the Impaler, doesn't
yeah,
it?
well,
Doesn't get right through there.
The character out of Pulp Fiction. The having the syringe onto the needle is the crucial part in that. So it's got to be second intercostal space. You have to be mid-clavicular line. You must be aiming for the middle of the chest, not out towards the axilla. So you're going right into that chest cavity, and you aspirate as you advance. That confirms that you're in the chest cavity. And that's the point where you then disconnect it, and if you're right, which you should be, this shouldn't be a vague diagnosis, you will get a rush of air. It is incredibly satisfying.
Yep, definitely very nice. And then in terms of securing that was some tape and a three-way tap.
Right.
And the three-way tap is going on to...
Well, it's going to reaccumulate, isn't it? So this is if you want to see how much air you can get out of a 40 gauge cannula, pull one out the pack and try breathing through it for a while. There's not enough. You're relieving the tension, you're not relieving the pneumothorax, so it will reaccumulate. So you secure it in place at the depth you've confirmed. You then don't want to be fiddling around with the end of it, so it's smarter to put an extension tubing on that, just like you do with intraosseous or other devices, and then have a three-way tap on the end of your extension tubing, which can be taped down. That way you can connect another syringe, aspirate it at your leisure if you think the patient is deteriorating, and eventually connect it up to a drainage bag.
Because he might well need that done again while he's in transit on the way to the hospital, mightn't he?
Oh, very, very likely.
What, like a second
so
14 gauge cannula?
No, but just re-aspirating it again, yeah. So if you can get it all set up so that you can do that easily without dislodging it while you're in the bumpy ambulance, that's
How long is it going to buy you, do you think? Like having decompressed a tension pneumothorax, have you bought yourself like half an hour before you need to put in a definitive
It depends on how
ICC?
fast it's accumulating. So big leaks, it may only buy you 5 minutes. Smaller leaks, it might buy you half an hour. In reality, it'll probably buy you about 10 or 15 minutes. It will relieve the immediate pressure but not drain the entire pneumothorax. It's quite common to need to re-aspirate it. You can just leave it open and hear the air hissing out. The problem with that is if it dislodges, and it may be that the reason it stops hissing is it was only just inside the chest cavity, and now it's migrated out with the movement as you're going around. So again, it's really nice to see a long one put in there. It looks horribly impressive and long, but that's the size needle you need to get into a chest properly.
What other things in terms of life-saving procedures might you have to do actually at the scene?
Well, firstly, airway. The chin lift, jaw thrust and Goodell airway help this patient enormously. But you need to keep on going back to that to make sure you've got a patent airway, and it may be that he could have equally needed to be intubated or laryngeal mask put down.
Assuming that you've got that in your little bag in the back of your car.
There, yeah, or you might just need to reposition. It might just be a question of repositioning the Goodell, some suction perhaps. There's quite a lot of blood around, so there's plenty more to be going on with airway.
Yep. Any other life-saving things that you could think of that you might do at the scene, Gary?
Well, we've already had two. The patient had a almost obstructed airway, which has been unobstructed with the Goodell airway, but that's not a definitive airway. In fact, most patients will breathe once you've cleared the airway. So that's been dealt with, but that is still a potential problem. In terms of breathing, the immediate life threat here is a tension pneumothorax, which has been dealt with. And as we just discussed, that's a temporising measure, so that may need to be looked at. In terms of circulation, yes, you can get major arterial hemorrhage. That was dealt with by reducing the open femur, but you can get massive blood loss from there as well. So tamponading bleeding points, particularly arterial bleeders, is life-saving at the scene.
I'm thinking how lucky it was for this doctor that he only had one patient to kind of continually reassess on this loop. It would have been mighty difficult if there'd been more than one.
And this one hasn't got any IV access just yet, has he?
No,
I don't think.
no.
So,
I think the doctor said he only had a first aid kit. It's pretty good he's got a Goodell in his first aid kit.
Yeah.
But that's not uncommon. Most people will not have IV fluids within their bags. The question now is, but ambulance will. So the question is, are you going to hang some IV fluids now?
Yeah.
On the way to hospital or at hospital, so
Yeah.
I guess we'll see what the doctor does.
Yeah. What would you do?
For this guy, he really needs to be in hospital. His airway needs sorting, his breathing needs sorting out. He's described as being tachycardic with a thready pulse, but he's got a radial pulse, so he's doing okay. I think I would want to get him moving to hospital quick, smart, and then it's presumably about 15 minutes to hospital if that was the response time. So you've got about 15 minutes en route to get some IV access.
I wouldn't be putting in an IV in a bumpy ambulance myself.
Oh, you can.
could be
You
having
can.
a go.
You can. The majority of it will be on straight roads.
You guys
going
are better
through.
than I am. I'd be doing it at the scene, I think, but I guess that's the call, depending on, what your experience and equipment is, and whether he's got a nice big vein that's singing out "stick me," or whether he's already shut down.
but also whether you're dealing with a real and life-threatening emergency, which is what the interventions have been all about so far on the scene.
Yeah.
So I think in this case, for him right now, IV access would be nice, but I wouldn't be hanging around for it.
Thank you for watching this program, and be sure to have a look at the second program where we follow the patient's progress and the GP's management once they arrive at the emergency department. The crash simulation scenes used in this program were produced in collaboration with the WA Trauma Education Committee. The full simulation forms part of the Trauma Education Committee's Western Trauma course. And if you're interested in further trauma education, we highly recommend the Western Trauma course. For more information, you can contact the WA Trauma Education Office on 9346 3699 or email them at watec@health.wa.gov.au.